All right, let's get started. Hello, everyone, and thank you very much for joining us today. You probably know I'm Dr. Choll Kim, since this is my channel. I'm a spine surgeon in sunny San Diego, and I'm here with Doctors Irwin Goldstein, a world-renowned urologist and sexual medicine expert. You probably know that too. Dr. Barry Komisarak, neuroscientist from Rutgers University, and together with Sue Goldstein, I believe she's the incoming president of the International Society for the Study of Women's Sexual Health, ISWISH, right? Uh, Among a bunch of other things, certified sexual educator. She's the glue that holds the San Diego Spine Sexual Medicine program together. And that's not that easy. We've been going strong since about 2016. So today, Dr. Goldstein will give us a short presentation on one of the ways that we use to identify patients with pelvic disorders, specifically patients with sexual dysfunction or even urological urinary dysfunction due to neurological causes. And it's kind of complicated, but this is one really objective way that we do. And Dr. Goldstein, prepare yourself because he's going to tell us how he does this. And a lot of this information comes from all the insight that Dr. Komisarak provides for us when he basically tries to help us piece together what we see in our patients, which, all patients don't read the sexual medicine textbooks and the anatomy textbooks, and everyone's a little bit different. We often will get confusing presentations, atypical presentations, and Dr. Komisarak helps us understand that because the neurological system, as it relates to making the organs in your pelvis function well, is so complicated. It involves multiple different systems, the motor system, the sensory system, the autonomic nervous system, the spinal cord, the brain, etc., along with all the hormonal activities and then all the anatomic causes. So it's clear why we need a multidisciplinary approach to take care of these patients. It's clear why many of you that are tuning in because you're having a hard time figuring out some of the answers to your questions, because part of it, we don't have the answers. And this is why we spend so much time talking, analyzing, and being very careful about how we take care of our patients. So having said that, I'm really excited to have Dr. Goldstein give us a presentation on neurogenital testing. A couple of things. One, please use the chat feature to communicate with us. Say hi, tell us if we're doing something goofy, propose some questions that we'll answer during the break. If you don't know how to use the chat feature, if you're on a PC, the bottom part of your Zoom window, there's something that says chat. If you click on it, it'll open up a little sidebar. Just make sure that when you type into the chat, you notice who you're sending it to. Send it to everyone, to as many people as possible so that we can share in it. I believe that when the attendees send us questions and comments, only the panelists can see it, and then the panelists, when we respond, let's try to respond to everyone so everyone can participate. And then after the presentation, we'll have a live, all of us will just talk live and answer questions, a lot of which will be called from our chat, as well as some of the questions that people sent us ahead of time by email. So sorry for taking so long, but let's get started with Dr. Irwin Goldstein.
Whoa.
I want.
Wait. Okay.
Hi, everyone. Thank you for listening to this webinar. This webinar is focused on how we work up patients with persistent genital arousal disorder or genital pelvic dysesthesia. This webinar is focused on how we do diagnostic testing for these patients. We need to select the correct patient with persistent genital arousal disorder or genital pelvic dysesthesia for corrective, definitive spine surgery if that is appropriate. This webinar is a first. We have not really yet focused on the diagnostic evaluation of persistent genital arousal disorder or genital pelvic dysesthesia patients. From the patient's perspective, diagnostic testing is the key to understanding the best management strategy. From the spine surgeon's perspective, the more highly selected the patient is with a true spine pathology for the genital pelvic dysesthesia or persistent genital arousal disorder, the better the surgical results will be. I always say persistent genital arousal disorder or genital pelvic dysesthesia is a monster condition. Persistent genital arousal disorder or genital pelvic dysesthesia can be caused by over 50 different recognized pathologies. So, accurate, non-invasive diagnostic testing is the key. I want to thank the amazing, awesome, fabulous, incredible spine sexual medicine team. First, of course, is my wife, Sue Goldstein. She's a sexuality educator and researcher. Sue is current president-elect of the International Society for the Study of Women's Sexual Health. Sue is the glue and real liaison between the three groups, San Diego Sexual Medicine, Excel Spine here in San Diego, and Rutgers University in New Jersey. Next member of the team is Dr. Barry Komisaruk. He is the neurophysiological brains behind the spine sexual medicine team. You will see his knowledge embedded between many slides in this talk. Finally, Dr. Choll Kim. He is the caring, passionate, skillful, artist-like surgeon who fixes patients with spine pathology through a 7 millimeter incision. Today, I will talk on the neurologic diagnostic testing in patients with persistent genital arousal disorder or genital pelvic dysesthesia. This talk is divided into 3 sections. Let me spend a few minutes on what is persistent genital arousal disorder or genital pelvic dysesthesia. I will always say persistent genital arousal disorder or genital pelvic dysesthesia is a monster. Please look carefully at this drawing by Lydia F. This drawing is worth 1,000 words. This drawing represents the impact and violation experienced by the artist from her lifelong symptoms of persistent genital arousal disorder or genital pelvic dysesthesia. Persistent genital arousal disorder or genital pelvic dysesthesia is highly associated with depression, unhappiness, shame, worry, and suicidal ideation. It was a suicide more than 5 years ago, Leah P. from Denmark. That was the motivation that allowed us to start the spine sexual medicine program here in San Diego and Rutgers University. Okay, take a deep breath and not be overwhelmed. It is my job today to teach you. This next slide depicts on the left the somatosensory cortex of the brain, where the brain processes sensory information from the entire body. Say 7 o'clock of this slide shows the tongue, 9 o'clock shows the lips, 10 o'clock shows the hand, 11 o'clock shows the elbow. Specifically in the rectangle on the upper right, that is the paracentral lobule. This is the region in the brain that processes sensory information from sacral nerve roots S1, S2, S3, S4. This includes information from the lower extremities, genital region, bladder region, rectal region. Persistent genital arousal disorder or genital pelvic dysesthesia is considered to exist if patient's symptoms include persistent or recurrent, unwanted or intrusive, distressing sensations of genital arousal for more than 3 months. It may include other types of genital pelvic dysesthesia symptoms, buzzing, tingling, burning, twitching, itch, pain, other than arousal. Most commonly experienced location of the symptoms is the genital, clitoris or penis, but also could be in other genital pelvic regions such as mons pubis, vulva, vestibule, vagina, scrotum, urethra, perineal region, bladder, and or rectum. Again, I'll repeat, the paracentral lobule represents in the brain where sacral roots S1, 2, 3, and 4 are processed. Okay, this next slide is my favorite slide. Again, thank you, Dr. Barry Komisaruk, for your amazing research. In the lower middle, in the red rectangle, we have
Jesus Christ.
okay, this next slide is my second favorite slide. Again, thank you.
Okay.
Okay, this next slide is my favorite slide. Again, thank you, Dr. Barry Komisarek, for your amazing research. In the lower middle, in the red rectangle, or in the upper left, in the red circle, is the paracentral lobule, again representing the region of the brain processing sensory activity of sacral nerve roots S1, S2, S3, S4. Now, in the upper middle, fMRI, functional magnetic resonance imaging study, this is Dr. Komisarek's research. The woman was voluntarily asked to touch her clitoris and record the activity in the paracentral lobule. Can you see that? It's about the size of an olive and it's red. Now, contrast that to the upper right functional magnetic resonance imaging, fMRI. This is a woman having a PGAD episode. Look at the severe, spontaneous, she wasn't asked to do this, intense activity in the paracentral lobule that occurs without the patient's permission. It is not voluntary and it is unwanted. This is the reason why persistent genital arousal disorder or genital pelvic dysesthesia is a monster. Comparing the size of the olive to the size of, let's say, a grapefruit, that is unbelievable, unwanted, intense activity in the paracentral lobule. Okay, this next slide is my second favorite slide. Again, thank you, Dr. Komisarek, for all your research. If persistent genital arousal represents unwanted, severe, spontaneous, intense activation of the paracentral lobule without the patient's permission, those are the two fMRIs, and it's the one on the right showing the intense activation. Then let's look at the bottom of the slide. In the bottom of the slide,
Jesus. Oh my God.
we have now discussed. Okay, this next slide is my second favorite sense activation. Then let's look at the bottom of the slide. In the bottom of the slide, where is the trigger coming from? So if we can find the trigger and locate it, we can best manage the condition. An expert panel convened and consents to divide the highway of sensory information from the genital lower extremity region all the way up to the paracentral lobule in the brain into 5 regions. The first region, the one on the left, is the end organ. This consists of the genitals, most commonly, also the bladder and rectum, and also the lower extremities. Region 2 is the sort of highway between the end organ and the beginning of the spine. That's the pelvis and perineum. It involves the pudendal nerve in particular. Region 3 is the bottom of the spine called the cauda equina. The genuine spine is region 4 that starts at T12 and at the conus medullaris, and region 5 is the brain. This consensed ability to divide the highway into 5 regions has been extremely helpful. We have now discussed persistent genital arousal disorder or genital pelvic dysesthesia. We now recognize its unwanted, spontaneous, intense activity in the paracentral lobule coming from somewhere, region 1, region 2, region 3, region 4, or region 5. Now, why do we do neurogenital testing? This next slide discusses the why. Neurogenital testing is non-invasive. Neurogenital testing assesses the integrity of sacral nerves from the genital region and the non-genital lower extremity region. If a patient with persistent genital arousal or genital pelvic dysesthesia has a history consistent with cauda equina pathology, such as low back pain, car accident, fall downstairs, fall onto coccyx, fall while skating onto the buttock area, dysesthesia or weird or unusual feelings in the lower extremities, buttocks region, posterior thigh region, posterior calf region, history of sciatica, the pinched nerve that involves referral pain down a leg or both legs. These patients should consider undergoing both non-invasive testing with lumbosacral MRI and neurogenital testing. These non-invasive tests should be performed prior to more invasive tests, such as transforaminal epidural spinal injection. This latter test involves a sterile procedure, a highly specialized provider, fluoroscopy, sedation, and epidural injections. In summary, non-invasive testing should precede more invasive testing. This next slide is the management algorithm for patients with a history consistent with persistent genital arousal disorder or genital pelvic dysesthesia. Let's go through this rectangle by rectangle, starting from the top to the bottom. The first rectangle is the history consistent with the disorder, unwanted, intrusive symptoms of unwanted arousal or dysesthesias, burning, itching, pain, etc. The second rectangle is a history consistent with cauda equina pathology. We've already discussed this also: low back pain, car accident, falls onto the coccyx region, weird or unusual feelings in the buttock region, posterior thigh region, posterior calf region, history of sciatica. Now, the next two rectangle lines are marked with a red rectangle. These are your non-invasive diagnostic tests. Now you can start on the left with the lumbosacral MRI and then do neurogenital testing, or you can start on the right, starting with neurogenital testing and then getting a lumbosacral MRI. The order of those two tests is not that relevant. Finally, based on the results of the non-invasive testing, then the second to last rectangle is undergoing the transforaminal epidural spinal injection for lumbar pathology or the caudal epidural for sacral pathology. And then finally, if everybody passes the tests and they're all positive, then spine surgery could be considered. This next slide is real important, and there's lots of information on it, so we will go slow. The upper image shows green nerves that are part of the sciatic nerve, and yellow nerves, which are part of the pudendal nerve serving the genital. The sciatic serves the lower extremity, the pudendal serves the genital region. So you can see underneath the picture of an individual looking at the posterior aspect. You can see the gluteal region, the posterior thigh region, posterior calf region. Okay, this next slide is real important, and there's lots of information on it, so we will go slow. And yellow nerves, which are part of the pudendal nerve serving the genital. The sciatic serves the lower extremity, the pudendal serves the genital region. So you can see underneath the picture of an individual looking at the posterior aspect. You can see the gluteal region, the posterior thigh region, posterior calf region. These are represented by the sciatic nerve, which roots are S1, S2, S3, S4. And just to the pudendal region, that's serving roots S2, S3, S4, and they pass on the pudendal. You can see for the oval in red, which says S1, S2, S3, S4, that is the region served, as we've discussed, and processed in the brain in the paracentral lobule. Now, the nerve roots, when they enter, we're now going to look in the upper right picture, and you're going to see the nerve roots of S4, S3, S2, S1 enter the cauda equina. And then in their highway to the paracentral lobule, they pass through the lumbar region. So lumbar pathology, such as depicted in this picture, an L4-5 annular tear, the nerve roots from S4, S3, S2, S1 have to pass through the annular tear. Now, the lower pictures below impinge the sort of end view This next, you can see the annulus as the circular fibers protecting the inside, which is the nucleus. Above the annulus, you can see the epidural space. The epidural space is surrounded by the dura, and you can see the sort of end view of all the nerves in the cauda. Now, the picture on the right shows a break within the annulus called an annular tear. The nucleus extrudes into the epidural space, impinges, and mechanically and inflammatory-wise irritates the nerves within the cauda, causing them to fire and result in unwanted, intrusive information passing from this annular tear irritation up to the paracentral lobule, resulting in the persistent genital arousal disorder or genital pelvic dysesthesia symptoms. So in summary, information from the genitals and the sciatic nerve, which passes through the sacral roots, has to pass into the cauda through the lumbar area. If there's pathology in the lumbar area, it can irritate the nerve, and this would be a region 3 pathology that's causing the persistent genital arousal or genital pelvic dysesthesia symptoms. Okay, this slide summarizes the just 3 non-invasive tests for neurogenital testing. Why do we have 3 non-invasive tests? Again, just to reiterate, the sacral nerve roots, S1, S2, S3, S4, emanate from the genital region through the pudendal nerve, S2, S3, and S4, but also from the lower extremities, the sciatic nerve, S1, S2, S3, S4. So non-invasive testing for neurologic integrity has to involve both the lower extremities and the genitals. So the 3 tests are called the non-genital sacral dermatome test, which assesses the integrity of sacral nerves from the buttock, S4. So non-invasive testing for neurologic integrity has to involve both the lower extremities and the genitals. So the 3 tests are called the non-genital sacral dermatome test, which assesses the integrity of sacral nerves from the buttock, posterior thigh, and posterior calf region. And then the genital quantitative sensory testing, which assesses vibration, hot and cold sensory information from the genitals. And then the bulbar cavernosus reflex latency test, which tests the nerve roots S2, S3, and S4. And this involves a reflex where information passes from the genitals into the lower spine at the conus medullaris, and then passes downward through the cauda equina out to the motor nerves, causing the pelvic floor muscles to contract, in particular, the external anal sphincter to contract. This next slide summarizes the 3 non-invasive tests involved in neurogenital testing. In the box on the left, number 1 is the quantitative sensory testing, which does vibration, hot and cold of the genitals. Test number 2 is sacral and foot dermatome testing, which measures the nerve integrity of the lower extremities involving the buttock area, gluteal area, the posterior thigh area, and the posterior calf area and feet. And then the 3rd test is the bulbar cavernosus reflex, which assesses the reflex latency from tapping the genital to motor contraction in the external anal sphincter region. You can see pictures. Test 1, you can see vibration of the genital, and another box shows, another photo shows hot and cold of the genital. And you can see the picture in number 2, you can see vibration in the gluteal area. And number 3, you can see tapping of the genital area with subsequent measurement of the motor activity in the external sphincter region. And you can see on the bottom part of the slide the 5 regions. So based on these 3 non-invasive tests, there are signature results which identify the location of the trigger that's resulting in the persistent genital arousal. And we'll show that in the next slide. This next slide shows how neurogenital testing can identify the region. Region 1, end organ. Region 2, the pelvis perineum, region 3 the cauda equina, region 4 the spinal cord, or region 5 the brain. You can see in the description, you can see actually in the rectangle that's red for the cauda equina, where we commonly see patients who have triggers for persistent genital arousal or genital pelvic dysesthesia. The genital quantitative sensory testing would be abnormal. This involves information passing from the genital to the paracentral lobule. If there's pathology in the cauda equina, such as an L4-5 annular tear, that test will be abnormal. The non-genital sacral dermatome testing would also be abnormal because the annular tears, say at L4, L5, will interfere with sciatic nerve information from the lower extremities passing to the paracentral lobule. And the bulbar cavernosus reflex latency testing will be abnormal because, again, tapping the genital and measuring activity that goes through the cauda equina up to the conus medullaris, or the bottom part of the spine, would also be abnormal. Now, if we look at regions 1 and 2, the genital sensory testing would be abnormal. Again, the information from the genital to the paracentral lobule that passes through, let's say, a pudendal nerve problem, that would be abnormal. But the non-genital sacral dermatome testing, which has nothing to do with the pudendal nerve, has only to do with the sciatic nerve, that would be normal. So the signature here would be that if the sacral dermatome testing were normal, but the genital quantitative sensory testing would be abnormal, and of course the bulbar cavernosus reflex would also be abnormal, that would signal regions 1 and region 2. Finally, if you look at regions 4 and 5, and region 4 is the spinal cord above the conus medullaris, the bulbar cavernosus reflex will be normal because information only gets to the lowest part of the spine in that test. So again, the neurogenital testing has the ability in a non-invasive way to identify the region that's triggering the persistent genital arousal disorder or genital pelvic dysesthesia. Well, thank you for listening. We're now up to the bottom part of the talk, the summary. So in summary, we've developed neurogenital testing to assess the integrity of genital and non-genital sacral nerves. Now, based on the finding of abnormal results of the 3 neurogenital tests, an abnormal treatable spinal abnormalities on MRI, an absence of pathology in regions 1 and region 2, and having a positive transforaminal epidural spinal injection, spine surgery can be successfully applied in these highly selected patients. That should result in significant symptom relief in some patients who have cauda equina pathology as the basis of their persistent genital arousal disorder or genital pelvic dysesthesia. Okay, this is the final slide of the talk, and thank you so much for listening. This is an important slide, and we'll try to spend a few seconds on this slide. In conclusion, neurogenital testing is non-invasive. Neurogenital testing assesses integrity of sacral, genital, and non-genital nerves. Pathologies within the cauda equina, a lumbar annular tear, lumbar herniated nucleus pulposus, or sacral tarlov cyst, are example of cauda equina pathologies. These pathologies could irritate and stimulate the sacrospinal nerve roots within the cauda equina, thereby conveying unwanted, intense, abnormal sensory activity from region 3 to the paracentral lobule. And this could lead to persistent genital arousal disorder or genital pelvic dysesthesia. Now, this is important. Cauda equina pathologies are upstream from the genital where the symptoms are occurring. Cauda equina pathologies are remote from the location of the perceived problem, the genital and non-genital regions that cause the persistent genital arousal disorder or genital pelvic dysesthesia symptoms. So here's the point. Since sciatica, we all understand sciatica, is a condition where pain is perceived to originate from the leg, but in reality it doesn't originate from the leg. It results Okay, this is the final genital from the leg, but in reality it doesn't originate from the leg. It It results from irritation of nerve roots in the cauda equina that is upstream of the entry of the roots into the sacrum. Therefore, final drum roll situation, persistent genital arousal or genital pelvic dysesthesia may be a condition where the symptoms are perceived to originate in the genitals, but in reality results from irritation of nerve roots in the cauda equina upstream of the entry into the sacrum. We therefore may consider clinically persistent genital arousal disorder or genital pelvic dysesthesia as a genital sciatica. Maybe if we called it a genital sciatica to our colleagues and to our patients, more people would understand this. Again, thank you so very much for listening.
Thank you, everybody. We now have some questions, and I'm going to send them to each of our speakers. So let's start with a question for Dr. Goldstein, and then we'll reach out to everybody else. Is the third test that you talked about today applicable to men as well as women?
Yes, it is. Can you hear me, by the way? Yes? Okay. So I am so sorry I screwed up that talk
Just move
with
on.
my goddamn pointer.
That was a great talk.
Oh my God, I'm so sad. We spent a lot of time on that. Okay, bubble cavernosus reflex, instead of tapping the genital around the clitoris and getting external anal sphincter recording, you tap the penis or glans penis and you get the same external. Boys and girls are basically the same for all of the tests.
That was a great question. We have a question now for Dr. Komisarek. You know the neuroanatomy, neurophysiology. Can an error during a cesarean section cause PGAD? You're muted, Dr. Komisarek. Press your space bar. If you hold your space
There
bar,
we go. That's good.
Okay. I've never heard of that. I really don't know. Some of the same nerves are involved, but that's really a very interesting question.
I have a thought. If you, the thing about surgery in general, C-section, kidney operations and whatever, is if you have an underlying spine pathology, now you go to sleep and you get positioned and twisted and turned on the bed, legs up in the air, whatever, you can actually irritate the cauda equina pathology because of the anesthesia and the positioning. I've seen weird surgeries result in PGAD that the surgery itself doesn't cause it. It's the manipulation of the spine. I don't know, Dr. Kim, if you want to comment on that, but we see that more than once.
I would say that probably occurs rarely. So two things. One, I don't think the C-section itself can explain a neurologic cause of PGAD because the nerves are coming from the back, going deep into the pelvis, and a separate set of nerves are coming across the front and over the uterus. So if it did occur, it would probably occur through either a local effect where there's scar tissue there or some kind of bad luck event where you like sustained an annular tear because you're susceptible to it. So I think that was kind of a rare bad luck situation and a coincidence.
I think it would be unlikely. If anything, the nerves would be damaged, and rather than having a hyper irritation, as in PGAD or GPD, would be a lack of sensation.
No, but you can damage a nerve so that it's hyperactive.
That's possible, but it would be referred to the uterus, possibly vagina, unlikely related to the clitoris. So, I mean, it's possible that it could. Where is the PGAD perceived? What parts of the body are is there a dysesthesia?
this is from the chat, so we really don't know. Whoever
Oh.
wrote that's welcome to add that in, but we're going to move on to the next question. Dr. Kim, can an annular disc bulge affect the pudendal nerve and irritate the lower sacral nerve roots?
Most definitely. So if you have a disc problem and the nerves that are going by that disc is being affected in any way, either through an inflammatory process, which is a very common cause, or a mechanical process due to a big, large disc herniation causing a mechanical compression of the nerve, anything going by it and distally can be affected. So if it's at L5, S1, it can affect your legs, but distally can affect S2, S3, S4, and those are all the nerves that go to your pelvis that makes up the pudendal nerve, and that's the majority of patients that we've been seeing with pelvic problems are patients with these subtle disc injuries that basically, together with a few other things, create a perfect storm, and the local inflammation in your spine kind of makes the nerve malfunction. And that, together with maybe a hormonal problem or a local genital problem, all comes together and you develop this horrible symptom. And when you try to treat all the things, if you just treat 1 or 2 out of the 3, you don't have much success. It seems like you need to attend to all 3, and the spine has been the last component to be recognized. I just recently came to know about it, mainly because of Dr. Goldstein. If it wasn't for Dr. Goldstein, I'd be just like every other spine surgeon in ignorant bliss. Now come to find out some of my most distressed patients are my patients with a dinky little annular tear that's causing huge inflammatory reactions, and they're so miserable. The patients that we treat successfully, they're my happiest patients. So as distressed as my normal spine patients are, patients with GPD, PGAD, it's amazing. And now that I think about it, I get it. I would much rather have a foot problem than a genital problem. And I would say if I surveyed people, it would be 9 out of 10. So
Point out the diagnostic.
that's my long-winded answer to your short question of yes.
Point out the diagnostic construct here. If someone had a pudendal related problem, one would do a pudendal nerve block to see if the symptoms would go away. And if they didn't go away, you'd have to think of diagnostic blocks upstream, such as a transforaminal epidural at the level of a sort of abnormal MRI at L5S1 or something like that. So
yeah, just to clarify, I may have missed the subtlety of the question. How do I distinguish between a problem caused by an annular tear or the pudendal nerve when the nerves going by that annular tear eventually make up the pudendal nerve? One simple pragmatic way to do that is to do what Dr. Goldstein said. If it's a pudendal nerve problem, if you block or anesthetize or alter the way the disc functions, and it's a pudendal nerve problem, you shouldn't notice any difference. You'd only notice the difference if you injected the pudendal nerve. So, the diagnosis relies on a lot of practical things where it would be like you go to the dentist with a toothache. You don't know which tooth it is because you don't have the ability, you can't see the tooth, the cavity on an x-ray, but it is causing a lot of pain. One way to figure out which tooth it is for the dentist to go one tooth at a time and numb it up. And when you get to the right tooth, you'll say something like, oh, my toothache feels better. And the dentist will say, well, that's the tooth with the cavity in it, even though I can't see it. And if it's severely painful, there it is. That's kind of like how we think about it. It's kind of like checkers. I think Dr. Goldstein and Dr. Komisarak, they think more like chess and go. I'm more checkers. But that's how I help with the decision-making process of, is it the spine? Is it the pudendal nerve? Is it the brain? Is it the vagina? Is it the uterus? Is it the bladder? Those questions are really critical. And the neurogenital testing helps me confirm that diagnosis in addition to that kind of injection checkers approach. What Dr. Goldstein's talking about is the chess assessment of the situation. I'm doing the checkers assessment.
Well, Dr. Goldstein, if we go with the checkers assessment for the pudendal nerve, how difficult is it to block the pudendal nerve to see if that's the problem? Do you have to go to the OR?
no, you do not have to go to the OR. This is all done as an outpatient procedure. There are 3 locations of the pudendal nerve that you can anesthetize. The pudendal nerve comes around a bone called the ischial tuberosity, or what we call the sit bone. So just medial to there is the sit bone. A little higher up is Alcock's canal. This is where the bicycle riders sit and injure their pudendal nerve. And then either put your finger into the vagina and feel a notch on the ischial bone called the ischial spine. The penile nerve is right there. If you touch on the spine and the woman jumps, you can just inject lidocaine in and around the ischial spine. So all of this can be done in an office setting. And what's fascinating is if you have a patient with intense PGAD at the time, then you provide the block in the area where there is tenderness, the PGAD goes away, you can assess with high likelihood that the PGAD is coming from region 2, the pelvis perineum region. But if they have pain in the ischial spine or around Alcock's canal, and the blocks do not relieve it, and there is an abnormal MRI and an upstream injection and neurogenital testing is consistent, then that's region 3.
And I could just add that it's possible that if a woman has pain in the clitoris and you do a nerve block, the pudendal nerve block, it's possible that her clitoris would become numb, but she still has pain in it because the irritation is upstream. It's like the genital sciatica.
Yep.
So that's a very puzzling to some people, but that makes the diagnosis very clear.
Dr. Kim, we're going to change the topic a little bit. Can an annular tear repair itself such that the bulge reduces and the infringement on the nerves resolve itself, or does it always need to be surgically repaired?
Great question. It usually resolves itself. It usually heals, and it usually gets better symptomatically through a variety of mechanisms. It's not exactly healing. It's the body basically compensating, accommodating, and kind of modulating its response to that lesion, because there is some healing, but when you develop an annular tear, the annulus will not heal very well. It's one of those, it's like cartilage. Once you injure cartilage, it doesn't heal very well. So, but the body's very good at kind of accommodating, one of which is turning off the inflammatory system. So most patients with annular tears, they may not even know they have an annular tear. But that doesn't mean that some patients with annular tears don't have big symptoms. It's just a small proportion of them. So I think that's one of the reasons why this is so confusing. After a while, when you see so many annular tears that are asymptomatic and somebody says, I think my annular tear is causing these huge symptoms, it's easy to say, it's easy to conclude it's unlikely, but I personally have come to find out that is the wrong way of thinking. What you need to do is identify that small proportion of patients that have that annular tear that asymptomatic. So if you get an annular tear, you find it on the MRI, you could have symptoms, you can get better, you get another MRI later, you could still have that MRI. So that's my long-winded way of saying annular tears don't heal very well from an anatomic perspective, but most patients' bodies and their healing mechanism deals with these annular tears to the point where most of us don't even know we have them. Most of us.
Segueing back to neurogenital testing, Dr. Karmasarik, I'm not sure if you're the best person for the question, but I'll ask. How do the results of neurogenital testing compare with EMG findings when we're talking about the lower extremities?
Well, Dr. Goldstein is really doing that, but you don't. The bulbar cavernosus reflex is kind of an EMG, isn't it?
So
yeah, but let me answer that question because I know a lot about neuromonitoring. That's probably a question from Dr. Hagigi, who's a very high-level neuromonitoring physician and neurophysiologist. So in EMG, the way he's thinking about it, the way we get EMGs on our clinical patients and the way most patients that have had an EMG know about it, it is a motor test. It's not a sensory test.
Right.
So it's important to point out that the tests that Dr. Goldstein's doing is a patient is awake and they're giving subjective sensory feedback. It's not like an EMG or an SSEP figure. It's more, it's purely sensory by patient feedback. I hope that answers your question.
That question, by the way, was from a patient. But
Oh, that's okay. Great. Yeah. That's a high-level question.
But Dr. Hagigi has a question. He's asking, can quantitative electromyography testing of the external urethral sphincter or external anal sphincter help under heavy sedation help to diagnose this issue? And I'm going to turn that to Dr. Goldstein first and then Dr. Kim.
So I've never done those, so I can't really answer that. Because it's muscle based, it's motor, and the PGAD and GPD are sensory disorders. So it could be that they're not that successful, but it could be that they are. I just never have utilized motor recording to measure the problems with PGAD, which are really highways of sensory information all the way up to the part of the brain which process it, which is what we found out to be the paracentral lobule. I don't know how motor activity could predict the problem, but we would have to study that.
During surgery, which involves mechanical injury or like ischemic events, large sudden events, because the sensory and motor fibers are all in one sheath, it's kind of hard to mechanically injure one without the other. So it's simply that during surgery, you monitor anal sphincter motor function, assuming that if we are worried about anal sphincter sensation, that because the patients that are asleep, you can't ask them if they feel their anal sphincter. So you can only monitor their motor activity. That's the idea. It's slightly different than what you do, but the question is that I don't think anyone knows the answer to that question. We'd have to
perform
have a gold standard test. We'd have to have pre and post-operative results, and we'd have to do a whole set of studies where we try to correlate it. As far as I know,
we don't do any sedation to these patients, though. These are
right.
This whole process takes under 20 minutes to do the 3 tests.
Dr. Komisar, did you have a comment for that?
Just that if there would be a reflex blockage of sphincter function that could indicate damage in the sensory or the motor nerves or the conus medullaris in the spinal cord. If the stimulation fails to produce the sphincter response, which would be measured by EMG, then that would be some injury would somewhere along the pathway, the sensory or the motor pathway, would be indicated. But that's one of the things that you get with the bulbar cavernosus reflex.
You know what we could do very simply? We do during surgery, we get all these parameters because I neuromonitor during surgery for surgical neuromonitoring. And I always get a baseline. We should just basically see before and after surgery, since they're asleep, if there's a difference pre and post-op and correlate it with surgical success. We've been kind of trying to do that, but we need to come up with a protocol that can really quantitate, make it quantitative. You'll be surprised it's not that easy to quantitate neuromonitoring things before and after. So I'll talk to Dr. Hagigi and we'll get back to you guys next time we're in the OR together. Since it's something we do anyway, we just need to pay attention to what the data is giving us and open our eyes to the type of data that will answer that question. Because we're always looking for ways to improve diagnosis, improve ways to say, hey, your surgery's done, you're finished, you did a great job, now stop operating and go home, close the wound. If somebody could tell me that intraoperatively, I'd be
especially
a much better surgeon.
In the case of hypofunction, if you alleviate the herniation of the disc, it may restore the function. It may restore the reflex function right in the surgery.
We'll have to look at all that data. Hopefully we'll be collecting it as we go and we can just pull it from that data. But my guess is that there's so much information, it's continuous data inflow. We'll have to create like these filters and windows to kind of look at these things, but that's my thing.
For those of you watching this webinar, you now understand how this cooperative group works, because somebody has an idea and somebody else says, let's look into this. And over the last 4.5 years, this is how what we currently understand has grown from this cooperative discussion. Okay.
Can I address one question really quickly? Somebody asked, is there a list of people? Part of the problem is that probably the best list is the Ishwish list. Sue is the president of Ishwish. These are all the various physicians, therapists, providers, it's pretty multidisciplinary group that goes to meetings every year and care about this. That's probably the best directory from my perspective, because I'm so impressed with that group and how much they care about patients. But it's hard to get all three pieces in one city. And it's really hard to get all three of us to talk like this because I don't have meetings like this with any other group. But this is one where this is vital.
So this is an important piece of information for you to know. This, at the beginning, we started with a discussion that ISWISH had put together a consensus panel. They have published it. It's in the process of being published. And we are purchasing open access. Now, what that means to you is there's going to be a very long paper showing how to diagnose and treat PGAD, genital pelvic dysesthesia, that you can access through the Journal of Sexual Medicine. It's not out yet, so don't look for it yet, but it will be through Journal of Sexual Medicine. You'll be able to access that and download a PDF for free and bring it to your local provider so that he or
and
she
try to convince them to set up the same program.
Well, it starts with trying to
Similar.
convince them that what you have is a problem that's not made up, that it's legitimate, that there are ways of diagnosing it, and they can start on that diagnosis, and the ways of treating, and they can start on the pathway of treating. And when they get to the point where they're not comfortable or not capable anymore, they can then refer you to somebody else. But the biggest problem now is we have people who go to a physician who then says, "Oh, I wish my wife had that." I mean, many of you listening to this have heard this, and that is a big.
I think it's going to make life a lot easier on everybody once this paper comes out. And I want to say a couple of things about this effort. I've written a lot of papers myself. I've been part of consensus statements, and I've organized big groups. I've never seen a group of this many people be this involved and be this dedicated to produce a piece of information that is just mind-blowingly comprehensive and thought out. Having said all that, basically it happened because Dr. Goldstein, whenever he says he wants something, everyone just knows we've got to do it because it's like, our mentor saying it, but every morning on Saturday at around 5:30, and then other like 4-hour sessions in the evenings, he would drag all these people and we would write this manuscript on Zoom together and he would just make everybody do it. And it was the most beautiful thing I've ever seen. And now I want to start writing papers like that, but it is amazing. So when that paper comes out, that position statement, which is, I think there's like 15 authors, maybe 20.
Oh, 15
Yeah,
authors.
15 authors.
15, just think about 15
Everybody who's on
people
this
like
right
us,
now.
not like a bunch of residents. 15 Irwin Goldstein, Berger Mizrak, Sue Goldstein, Choll Kims, working together to create this thing that's going to basically help other people, other providers, and other patients kind of get care locally. And just think about it. They don't even think about this, but like if you're a business person, that'd be the last thing you want to do. Because right now, Dr. Goldstein's the only one that can really do it right. He's now made it so that all his competition can do it now. And that's what it's like. I mean, this is like I've never seen a group of physicians that truly care about patient well-being, and they just have it in their mind that this is a horrible problem, even though people don't think it is. When you look at it, it is a horrible problem. And making sure that it's done right. Making sure that we include all the people that participate in the decision-making so that we don't do anything kind of off the beaten path, and we know that we're doing the right thing and taking good care of patients. So I wanted to say that because it is amazing how much Irwin does. It's shocking. If I was like Irwin, I was like Irwin about 10 years ago, but I was only 40 something. I'm like slowing down and Irwin's going like this. So I don't understand it, but that's why I don't do anything without Irwin now. So that's my long-winded way of saying thank you, Irwin. Thank you, Sue. Thank you, Barry, for including me. We have about 2 minutes. We can try to answer one question, but I just wanted to get it out there that
I second your
I guess
emotion.
the next thing is for me to tell my spine surgery colleagues and do my part so that when other urologists, sexual medicine doctors elsewhere need to find a spine surgeon like me, they don't get that cross-eyed funny look, which I know most of you are getting from your spine surgeons now, but spine surgeons take a long time to convince. They're a tough bunch. So I didn't want to jump the gun too early, but with the publication of that position statement and the soon publication of our clinical experience, hopefully more and more spine surgeons in the country and the world will start being more aware of this and making it easier for everybody to get the care that they need.
I appreciate you saying this, because when we do these programs, it's not because we want to steal patients from other people or that we're looking for the business. We want to help patients. And the fact is that right now, Dr. Kim is the only one comfortable doing surgery in the spine for sexual health issues. Dr. Goldstein is the only one doing some of the testing he's doing. Dr. Karmazar lends his brains at no fee to the patients to help us with all of this. And we're doing this because we care about you, the patients. I want to close with a comment from our patient Sonia. Thank you for this. Just when Dr. Kim takes off his scrubs, there's a Superman uniform underneath.
That is so not true. It is, I'm the checkers part of the game. I just do what I'm told.
That's the fun
That's the
part.
key.
Yeah, right.
All right, it is 5 o'clock. Thank you all for joining us. So a couple of things will happen. One, this is on Facebook, so you can go back and look at it at a later time. We'll record this and send it to you by email, so you can, if you can't get to sleep tonight, you watch it again, you're like, and then stay tuned for ongoing more presentations, and feel free to let us know what topics you want us to discuss, how we can do better with this format, because, you know, we don't want to spend an hour doing nothing. We want to do something that's also meaningful. So give us some feedback. And once again, thank you all for joining. Happy New Year. Stay healthy. Stay safe.
Get vaccinated.
And get vaccinated.
Thank you.
Thank you.